Good afternoon, everyone. My name is Dave, and I'm a paediatric PEM consultant from the Northeast. Can you see my mouse move? Yeah, spot on. In spite of the selfie, I'm not obsessed with point of care ultrasound, but I have been asked to share some things that we do in paediatrics. Hopefully, some of it will be either new, novel, or interesting. Like I say, just feel free to jump in. So, jumping right into a little game we're going to play. Are you guys? So I gather that some of you do some paediatrics. You're EM or PEM trainees, vaguely, yeah. So this will be kind of lie within your remit, I suspect, at some point. So it's your first night shift. You've just rotated to a new hospital, and you've got this 5-month-old baby's brought in, and he has woke up early hours of the morning, and he isn't moving his arm. You get bits of information as you go. So the family are known to Children's Services. Stepdad did the last feed at around about 11 p.m. Boo, stepdads, or dads in general, unfortunately. Sorry, yeah, it's always us. Fingernails are a bit grubby, and the baby grows a bit grubby. Mum tells you, mum's accompanying him, she tells you he's just started to roll. 4 or 5 months. There's nothing else to find on examination. So the question is, what do you do? All right. So you're going to keep this in your head, and we're going to come back to it at the end. Do you speak to a senior? Do you do a background check with Children's Services? Do you do some X-rays, or do you do something else? So along with cardiac and palpating the femorals, there's always something that we tell you in peds never to miss, isn't there? So let's see what we think about this. Some nods. Anyway, on with the real part of the talk. So we're going to have some cases as we go, and like I say, hopefully they'll illustrate things maybe in a slightly different way to what you're used to. But I'm going straight in with the trauma. Can you believe I'm going there fast? I wrote my dissertation on fast, so let's have a big argument about it. So 15-year-old girl has nicked the family car early hours of the morning. This is, again, the pre-alert you guys probably don't want. You're in a trauma unit. These are all real cases. Everything you see today has been written exactly as it's written in the notes by me, sometimes with the actual triage details. So yeah, this girl, this sister and brother crashed into the side of a house, and they self-extricated, but there's significant damage to the building. And on arrival, the registrar assessed them, A, B, C, D, E, and was fairly happy with A and B, but there was clearly some abdominal signs. We were a bit cold, but other than that, numbers were okay initially. We had a tense, tender abdomen throughout. So what happened was the registrar who was on early hours of the morning got a CT. Of course, it would fit with all recognized guidance that would be the thing to do. And this is what he got. All right. So guy in the red top just taking a drink. Do you want to talk me through that CT? He's pulling a funny face. Yeah, of course. None of us are going to talk us through this CT because that's not what we're here to do. Yeah, we can't reliably report CT. Unless he's a radiology trainee. I don't know who this guy is, but yeah, I certainly couldn't do it. So yes, this is what we got. Okay. So I came in at a reasonable time for consultant to start. I'd been in post about a year at this point, and I'd actually come in early to run a simulation. Little did I know there was an actual simulation unfolding in my eyes. All right. When I got there, this girl was quiet. She was much paler, cooler, and she had a neonatal blood pressure. All right, and was more tachycardic. So again, everything's written in the notes as it should, as directly copied. All right, we've got the correct spelling there of Morrison's pouch because that's how you spell it. This was a surgeon from my neck of the woods, from Durham Way, and that's the correct spelling. And this is what I wrote. What was amazing about this case, or I think was fun, is that because of distracting injuries and all of the abdominal stuff that was going on, I actually scanned, which is what you'll see I do for everything. I scanned the limbs, and we found a distal radius fracture, which I don't think we would have picked up on at that point. She had other problems to deal with. So put her in a splint, just a Futura, and then we dealt with all of this, okay? So this is what we found. Cine loops playing? Are the cine loops playing?
Yes.
Yeah, cool. All right, so you guys all know what this shows, yeah? So we're in the right upper quadrant and we're in the pelvis, all right? Shows some badness. It's called the bow tie sign, or the Americans. I'm in a group with a lot of Americans where we share cases in Connecticut and Massachusetts. They call this the TIE fighter sign from Star Wars. I've not seen Star Wars, so I didn't know what the TIE fighter was, but it's a bow tie. All right, so this is the point of this case. So 2 hours and 48 minutes later, this poor registrar or at this point, me, got a report back which revealed everything we already knew based on FAST. All right. So the greatest will in the world, as senior decision makers, what can we do with these CT images really? How can we reliably empower ourselves to make decisions? Well, for me in the trauma unit, what I then did is I did all of these things. So I spoke to the nearest MTC and I said, look, we don't have a report in the interim, but she's got a positive FAST. So we know based on even if you think sensitivities might be lower in the mid 80s, we know that we've detected some free fluid. So I activated the MHP, given my neonatal blood pressure and my tachycardia, and I just expedited this transfer. And I think FAST gets a bad rap. Like I say, I wrote my dissertation on this. This is quoting from ETC. I don't know if anyone's done ETC. It's an excellent course. It's a really nice one, and FAST appears about 30 times in the first 2 chapters. All right, because it is an excellent triage tool. Okay, it's a compartment triage: heart, lungs, chest, heart, lungs, and abdomen, and it shouldn't replace CT. No studies might look at this for interest sake, but no real argument you have with anyone should be trying to argue against POCUS versus cross-sectional imaging, because that's not a fair discussion and that's not what it's there to do. But it can do all of these things. It can be readily repeated and it can help you make decisions at that point. So you're not dependent on someone external, like an external reporting system like 4Ways is what we have up in the Northeast. I don't know if you guys have that, who report scans. I mean, some of the reports you get from them as well in the middle of the night, I taking the girl and the coffee with the coffee's laughing. So yeah, take it with an absolute pinch of salt. It's like crazy reports sometimes. So there we go. So quick little introduction with FAST, all right? They get more exciting as we go on. This was a 16-year-old girl who had this unusual story. She said she'd had a pop and candy sound when she swallowed over the past 2 months, all right, accompanied by a bit of discomfort on the upper right side. She was completely well, all right, normal SATs, she looked entirely normal, and she was seconds away from leaving the door to go to the urgent treatment centre. This was in 2018. I just done one of my first POCUS courses, and I knew that POCUS might have a role for looking at a few things here. You can probably guess what. And she was genuinely at the doors when I got her back and I said, can I have a little look at her? I was a registrar at this point, and yeah, I intervened, and this is what we did. So everyone happy with a bit of lung ultrasound? You've all seen it. It's the same in kids as it is in adults. So we used the high frequency probe. We're looking down between our rib shadows. We're looking for an echogenic pleural line, which is shimmering, all right, on her affected side. Sorry, that should have continued, which is the right side. We can clearly see that we don't have our lovely little ants marching on a log on that good side compared with the affected side. One more time. Completely static compared to the other side, all right? So I was like, this is unusual. Wow, have I really picked up this? And this was genuinely one of the first set of lungs I'd ever scanned in real life. So I hear you all say we need M mode as well, don't we? So I did M mode, and this is her compared with our examples. Do we think we're more of a seashore sign with the sandy beach and the shimmering pattern here caused by the movement artifact of M mode? Everyone happy with M mode? I'm happy to talk through it if not, but it's not physics talk, is it? We all know roughly. Yeah, she's definitely a barcode, isn't she? I was like, right, okay. So I hear one of you shout at the back, but hold on, Dave, you can't rule in pneumothorax, can you? You can just exclude it. You can hopefully exclude it unless we can find lung point to rule it in. So lung point's obviously that interface between normal lung, normal sliding pleura, and abnormality. And I couldn't find it anywhere on her, absolutely anywhere. So I began to doubt myself, which is what you do early in your POCUS journey. I was confused. She was very well. She had SATs of 99. And the reason why I couldn't find anything was because in this completely well girl, she had a complete hemithorax pneumothorax. Now, even in a major trauma, even when I was in Cape Town, this was more impressive than what I would have seen over there. So I couldn't believe what I was sat on. So we're PEM consultants, so we don't do a lot of stuff like this as commonly as you guys. But I aspirated as per BTS guidance. It was unsuccessful. I did a drain, and this girl later went on to have a VATS procedure, but she actually came back with a recurrence on the other side 4 weeks later. So I'd done 1 chest drain in 7 years, and then I got to do 2 within a month, which was fun. And she wasn't tall, particularly she wasn't Marfanoid, but what a fascinating afternoon for us, given that she was just about to leave for the urgent treatment centre. And you're listening in a busy department, breath sounds, the junior says to listen. You're kind of like, well, I just don't think it's half as reliable as what it should be, on an exam or a course, quiet breath sounds, resonant percussion, all of that. But POCUS is undeniable, I think, for stuff like this. So I'm going to try and give a learning point for each case. And, you know, studies have looked really at sensitivity comparative to chest x-ray. You all remember turning, you know, we used to turn the kind of screen on the side and flip the image and look across your pleural rim. And it's tricky sometimes. It can be hard, but POCUS doesn't have to replace an X-ray. It can, and I actually think chest X-ray is one of the worst tests we do in medicine, genuinely. And there's a couple of other things where I would genuinely make a case that POCUS could reliably replace an investigation, things like soft tissue foreign body, which we're going to come on to. But it's not meant to do that, all right? It's to get you from a position of a pre-test probability here to a post-test probability there, and it's a quick, easy tool. And I think this really helped this girl. So here's another case, which I think Gokul knows about this one. So another true story. So Saturday afternoon, I was asked to look at a well baby with a lump on his head, just gone 12 months. So I said, yeah, of course I will. And of course I brought my machine. So I had a look, and this was a well baby. And it had been a soft lump that was diffuse, but quite shallow, and was over the parietal skull with no reason as to why that would be there, no other systemic symptoms at all. So I did like what I would normally do, which is to extend my clinical assessment using POCUS. And because I couldn't infer a lot else about this lump, you know, there's a lot of differentials that us as pediatricians could think through. And I put the probe on, and this is what I saw. And it doesn't take any expert to say what it was that I saw. And I just said to the parents straight away, I said, the skull's fractured. Straight away. So I had quite an interesting little afternoon. I went round to a local radiologist and I told her what I'd found. And I said, we need to CT this infant, mainly because of obviously the concern about a lack of a story and about MRI, but also, you know, for the medical reasons, to look at the brain, to look at everything else, to ensure there's no expanding subdural, etc. And I was told this: you cannot see fractures on ultrasound. I said, oh, or in my head, I said, I assure you can. I've been doing it for 5 years. And I can direct you to some publications if you want that I've written if you want to find them. And look how good a fracture looks on ultrasound. I mean, so I said, okay, you can, but honestly, so there was also a big systematic review meta-analysis in the EMJ that looked at this exact topic, and it was very good in kids for skull fractures. So we got the CT, and it did show the fracture. All right. And of course, this had saved me so much time. So in this interim, I was able to do a lot of things without messing around waiting for any report. I was 100% confident about the fracture on the skull. And I rang my consultant colleague upstairs who was on for safeguarding. I did a background check with Children's Services. I dug into any background attendances with us. I spoke to the parents. I ordered the skeletal survey. I don't think we needed to do bloods, but, you know, all of this sort of thing I can be planning. And went back to parents, took a more in-depth history. And of course, then the mechanisms come out, all right? You know, oh, no, actually, hold on, there was this and there was that. So the one thing as a pediatrician I'll talk to you guys about, I don't know if anyone in the audience is hoping to do PEM or is currently doing PEM as a, you know, subspecialization, is, you know, much like our case at the start, is, you know, never forget NAI. But remember, if it's NAI, which will be less common than accidents. You know, there's accidents and then there's NAI, and even though NAI is common, if it is NAI, the family are lying to you. That's the thing you've got to always keep in your mind, yeah? It won't always be NAI, but if it is, they're lying. So we cracked on, we did all of this, and, you know, the outcome was fine for the child. More fractures, all right? So this was not too long ago. So this girl was a semi kind of serious gymnast who had landed almost on an outstretched arm and had some mid-shaft clavicle tenderness and a little bit of, you know, that purplish sort of hue that you get when you just know it's fractured. And this is she got an x-ray from someone and looked fairly normal to me, normal curvature, all fine. And it got reported actually quite quickly that evening. But before all of that, I didn't wait for this. I'd gone in and I'd scanned, and that's x-ray is wrong. It was definitely fractured, all right? It was clinically fractured, and it was fractured on POCUS. Mid-shaft, just where we thought. So what was lovely was that when she got to fracture clinic, the consultant over there, you know, they're lovely, aren't they, orthopedics? They said, don't worry, she's just sprained it, and it's a soft tissue injury. Luckily, she was already in the right treatment, which was a broad arm sling, all right? So just to show it's not a fluke, Here's another one, little one at nursery, was put into my trauma clinic for follow-up, which we run 3 times a week. Had a bit of a fall, but still wasn't moving that arm. These were the second set of x-rays that we've done. And I knew she was not right, and this is what we saw. So this is 2 minutes after this fracture, all right? So it is a thing. We don't always need to believe what we're told about x-rays or about bloods or about everything. There are other ways to do things. So we wrote that case up in Peds Emergency Care just because I knew there'd be a tip of the iceberg and a few more. So remember, POCUS can be used. It's an extension of your clinical assessment. It can be added in quick and easily to help with what you've, add to the picture that you already have. I was asked to look at a 5-year-old once in the same clinic who'd stepped on something sharp in his room. I said, yeah, I'll have a little look. And this was 32 days ago. He had a limp and then that settled. And then he returned and he had another set of x-rays of his foot and they were normal. There was no foreign body. And then he arrived with this funny granuloma on the bottom of the foot, which I was like, all right, something's going on. So let's have a look. So we're 3 sets of x-rays in now. This is the second set. You can possibly see the little, where we've had a little wound or whatever. A little bit of air tract, tiny bit of air. And I put the probe on and this is what I saw. And this enormous foreign body in there. And, even in transverse section, you can see the thickness of this object. It's pretty big. It's obviously very long. And I convinced orthopedics to come and have a look. I mean, pictures and take them to theatre. And yeah, this is what we saw, this massive barbecue skewer, and these things that you see. Anyone who used to go to theatre as a med student or whatever, you remember how massive these scissors are in theatre. So this is big, right? This isn't just a splinter. Pardon me. So I was like, okay, that's interesting. And yeah, that was a good outcome. Retrieving them yourself, I think, is a different kettle of fish. We always find foreign bodies now that are missed on X-ray. I've maybe got about 15 cases, but sometimes you've got to be pick the patient, pick the shift as to whether you go retrieving them. Sometimes I think it's better to just try to get orthopedics involved and show them your images, but we couldn't ignore it with this particular big one. Okay, we're getting more controversial now. So this is something that I like to do every time now for this kind of injury. All right, this was a girl who came in late in the evening, 10:30 at night. Department was heaving. She'd been at ballet. She'd done a spin move and she fell, and clearly her right thigh was the problem. Now, I don't know if any of you were working at this point, but this was about or what you were doing. This was a time when there's this thing about strep was in the news and everybody was just piling into the department telling us they had strep, and 2 extra people had died compared to normal on average, and the papers got hold of it, and everyone was worried about invasive strep. I don't think anything additional happened compared with other years, and it was the end result, but nonetheless everyone wanted to be checked. So our department was absolutely heaving, and I was in a position where I couldn't really move this girl around to X-ray. My plan would have been to do a ketamine sedation and either an image or obviously splint, but I couldn't do that. All right, it just wasn't safe within the department. I'd already stayed 3 hours later than I should have been. My other colleague, who was on the 1 a.m. finish, I think ended up staying 5 hours later. So it was all pretty heaving. So instead, I had a little look with ultrasound. All right, so I'm running the probe over her thigh. We're using the high frequency probe. We've got the kind of rec fem and the vastus lateralis muscles. We've got everything in where we should. And we can clearly see here, bony fracture, all right? In discontinuity. In transverse, we're scanning down. We're looking like a CT scan, all right? So it should be a perfect semicircle. So the normal bit would be the bit at the end. That would be normal. That would be a fracture, all right? So instead, I didn't bother x-raying it. I just put in the block. Sorry, these should be plain. So here's me coming in. I'm well away from my artery and my vein. I've got my nerve bundle there. I want to be beneath both fascia lata and iliaca. I want to envelop this nerve, but not go through it. So look, I want to envelop that. And what was really lovely about this case was I went back in, and when I went in, this girl was like singing nursery rhymes with her grandmother, and it really made me, like, for one of the few times in my job, it really made me feel like I'd made a big difference to a patient. She was totally pain-free. So then we cracked on with the block, cracked on with the Thomas splint, and then we got our x-rays. All right. So this was the first time I did that, more from necessity, but I now do that every time. And my orthopedic team don't have a problem with it. It's like mimics almost pre-hospital management, doesn't it? You just, you're certain what you're seeing based on that. It's mid-shaft. You can calculate the distance from the physis, etc., etc. You can crack on and do the block. So I like winding up orthopedics. All right, I really like winding up orthopedics by doing this. So we get a lot of these kind of skateboard people who have a fall at a play park or a skate park, get our angulated fracture, and this is how it looks beforehand. All right, we've got our angulation, and everyone I'm sure has done who's done an orthopedic job is aware. Sorry, won't do what I need to do. If anyone's done the ortho SHO job, you know, you'd go there and you'd help with manipulations in adults, and you think you've got a beautiful end result clinically, but then you look and you don't. I'm just reviewing the X-ray checks this morning when I'm in the department, and the same thing's true. You know, what seemed to be a lovely reduction under fentanyl and Entonox turns out to be terrible afterwards. So we don't have fluoroscopic control to do our X-rays, but we can guide it with this. So I try to do this every time. Usually I'll be in the room anyway, monitoring, keeping an eye on the child from either the ketamine perspective, doing ABC, A and B, or from the point of view of if they're doing just a pull under Fentanox, just to make sure they're not kind of torturing the child too much. So yeah, so I tend to check it with this, and I think it's working really quite well. And that was how we were after, healing nicely. Okay, so this gets a bit more technical now, more interesting. So this was a girl who was in on a Saturday, and she'd came in 9 days ago with sore throat and then returned with pyrexia, was felt to be viral. She was previously fit and well, and she came with a little bit of periorbital puffiness. She had a bit of potential that she was about to spike. A mild temperature was there. She looked fine otherwise, but the team who assessed her initially thought she had a mild left lid ptosis. So some clever sausage did some bloods, all right? And even for us, these numbers are fairly impressive, you know? I was like, okay then. So I came in the afternoon and was just catching up on all of this. And naturally, they went and took her for a CT, concerned about, you know, potentially invasive infection or orbital involvement, cellulitis. And they got a diagnosis of pansinusitis, which we can see. They then went back and forth, had contrast, same diagnosis. The EN team eventually recommended MRI. This wasted about 4 hours. And this was the point when I turned up. So they brought her back. I never forget. They brought her back from MR at this point, and they said, "Dave, you need to come in and look at this girl straight away." And she was in bed. She was completely difficult to rouse, and to me, absolute horror, she had a fixed dilated pupil on the left side, with no orbital signs that would explain it for me. There was no chemosis. I don't know if any of you have seen proper chemosis yet. You know, where the membrane folds out, proper orbital cellulitis. This was not that. This was something else. Okay. So we'd had a CT that said it was fine. It was just a bit of pansinusitis, nothing else. We had an MR at this point that was getting reported, which I'm going to tell you about in a second. So I had to act. I had to understand why this girl was trying to die in my department on us. You know, this is even scarier, isn't it, than a little 3-month-old who comes in cardiac arrest. This is someone's 10-year-old. Yeah, this is like the stakes are as high as you can possibly get. So she had a massively enlarged optic nerve sheath diameter. So this is orbital pocus, ocular pocus, which I do quite a bit. And I was like, wow, 0.68, that's pretty wild, no matter where you're measuring from. I don't know if anybody's seen this. Hands up if anyone's seen ocular pocus yet. Yeah, couple, cool. So a few bits to talk about this. We can talk through it at the end. But yeah, so I gave some hypertonic saline, and I was arranging transfer very quickly. But something really, really fascinating happened after that. So that's how you do it, dead easy. Anchor your hand on the probe, probably showing a little bit of mild papilledema there. And again, we can talk through that at the end. Papilledema, protrusion of more than 1 millimeter. So got the MR back, okay? And what I got was nothing major. Pansinusitis, again, you can see it. And possible meningeal irritation, all right? So we get that quite a bit in a kid, but it certainly didn't explain a fixed dilated pupil, and it didn't explain, you know, really probably didn't explain reduced GCS to that extent. So I'm on the phone to the transfer team on one phone, and I'm saying, we need to get this girl out. She's in extremis. We've paxed over the images to neurosurgery. Can we do an acute transfer, or do we need to just scoop and run with one of us? And when I was on the phone to the transfer team, giving them all the information, you know, the dog's name and their address and all of that sort of stuff, I got a frantic wave from the nurse. And she said, "Dave, you need to take this call." And I said, "What do I need to, what I'm trying to talk to Nectar, which is our transfer team." And they said, "No, you need to get off the phone straight away. It's the neurosurgeons. They've got your refer a patient. the images had been sent across. On that note, you know, I would say this: refer patients. Fun, isn't it? If I could design a specialty where I would really think refer a patient should not be used, it would be brain surgery. Like if I could up the stakes any higher, like give that to dermatology, give that to like, do not give it to brain surgery for God's sake. So anyway, yeah, they're on the phone, and she says, "You've got to get off the phone now." So I was like, "I'm really sorry, 2 secs." And it was the neurosurgical reg at the tertiary centre, which was not us. And she said, "We need this girl here yesterday." We said, "She's got an expanding subdural empyema and you need to get her here." So I'm like, whoa, 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 hold on. I've got 3 radiologists telling me that everything's fine. I've got some bloods that I'm worried about, and I've definitely got a POCUS that I could put a lot of faith in myself. I could put probably more specificity into the POCUS than I could into what this means, because this could be lots of things, couldn't it? You know, this could be appendicitis. Like, I've seen it. So I'm like, what on earth's going on? And we transferred across time critical, and then something happened that I've never seen happen in my career ever. She went straight from our centre into theatre at another in Newcastle without any parental consent. She didn't sign a consent form. They literally did brain surgery without parental consent and saved this girl's life, thankfully. So we wrote her up as well. Her case is there online, and she's lovely, and she sometimes comes in as well with other things. So yeah, there are lots of studies looking into raised ICP. There's been a lot more recent ones. This at the time was when I wrote the talk initially, that case. There's been a couple, it's been a few good ones this year, really, really good numbers. The best study I ever saw was looking at POCUS, where it was application of hard collars in healthy volunteers. So just, you know, doctors or med students or something, where it showed a real-time increase in raised optic nerve sheath diameter secondary to ICP, which I just thought was absolutely fascinating. One, because we know hard collars are not great, you know, we don't use them at all now, but also on the basis of that real-time increase in ICP. So that was pretty fascinating. So I thought that was a big win for POCUS there, given that the DATE team had done really well, they'd managed to really well, but they didn't really have a kind of, at this point, they didn't really know what to do. Okay, so this is my little friend Darcy, and this picture's shared with full consent. And this was more recent and a bit more serious, I guess. This little girl came in on a Sunday, and she'd been treated for possibly a sty of her eye, and she looked all right. She came to us. She'd been back and forth to the pharmacist, and she'd done hot compression bathes and stuff. But the worry is that when she came to us, there was just a very subtle thing that was making me think, okay, that's just slightly different size, this eye, and there was no sty, there was no meibomian cyst. So I was like, right, okay, don't think it's that. Is it infection? Is it not? So I did what I always do. You know, I can't really do anything else there and then. I'm certainly not going to try fundoscopy, because we all know that's a complete myth and legend. So I put the probe on, and it's going to play it a few times, or it's going to play itself a few times. So same image, yeah. We're looking back. We've got optic nerve sheath is there. Is it hand up? Is anyone seeing anything else? I couldn't hear, but hand up. I mean, the clue is there will be something there, but yeah. So yeah, I saw this horrific, absolute terrifying badness. Okay, and I just went out the room and texted one of my other consultants, and we talked about scans a bit. He sometimes texts me, and I just said, I've just found badness behind this girl's eye. And I just, as a kind of a pediatrician, I was thinking, oh, I think I know what this could be. So this whole thing of, you know, back and forth, maybe mild proptosis, if you call it that. This was a kind of heterogeneous something that shouldn't be there, obscuring this optic nerve sheath, this optic nerve, this big thing. And just from doing lots of scans and unfortunately finding some badness, this is what badness looks like. It's very heterogeneous. It doesn't look like any other tissue. And we've got a case series that's just been accepted in BEMUS, and it's to do with cancers that have presented to the PZD, six cases, which I didn't have time to include all. So we went round and made a massive case to get her an MRI that afternoon, which I got without we didn't need to sedate her, thankfully. And does anyone know what this is? This is very PEDSy. Sorry, I didn't hear it. Say it one more, louder. Not quite. No, not where it is. It could be, I guess, but it's actually outside of all that. It's kind of within the muscle. This is rhabdomyosarcoma, which is, if anything, even worse. This normally would just kill someone. This is what you don't want to have. So this was this, and again, this just talks about, again, all of this is shared with full consent from Darcy's parents, who brought me in a bonsai tree a little while ago, actually, which I'm trying to take care of. With a nice card, and she's doing amazingly well. All right, but we don't normally get that with rhabdomyosarcoma. It's normally found much late, and this is exactly what was said in the letter. We have a high expectation that she'll be fine. She's kept her sight, and he said she will live, which is great. So I think you never know what is there. All right. So hopefully with the cases, I'll let you guys read these and you can make your own mind up. But hopefully with some new applications of POCUS modalities, hopefully I've convinced you that each time we've added a bit of value or a bit of something different. And, you know, you can't be too, you've got to be a little bit willing to keep a high index of suspicion about things, even if you've got formal scan studies, or even if a radiologist is telling you, you know, you can't do something, or this isn't this, or this, you know, you can't see fractures. So those are the cases, right? So we're going to carry on with just a few thoughts. So if I hadn't already convinced you, I might talk you through some of these things as to why POCUS is good for your department, for the family, for the department, for yourself, and maybe for the trust even. You know, on our PEM grid training, if you have a look up at it, I just looked at the other day, and they talk a lot about POCUS, and I didn't realize that actually. They say, you know, it's a strong ethos of POCUS, kind of research different things, and I was like, all right, so that might potentially attract some trainees to the region. So that's why I put it on there. But that's not really what I'm going to tell you about. I'm going to talk to you about the wonderful world of pediatrics, all right, which is where headache doesn't normally have a head cause, and tummy pain may not have a tummy cause, and it might be pain all over. We might have a kid who looks like this, who's a bit upset with a scratch, or we might have a full-blown banana arm. You know, they might come in with a 90-degree banana arm and be fine. So they're really tricky to work out. And this was this wonderful paper that I read that you might know Damien, who talks about the kind of extrapolation of findings that you need to employ during a pediatric examination. You know, you get one chance to examine, and you might try and feel for a little child with autism, you know, feel where he's sore, or press along the tibia for a toddler's fracture. Well, that's pretty much nonsense in my opinion. I would never trust that alone. It's hard, it's tricky, kids get upset. It'll be variable. We'll have pain in the knee when it's the hip when it's the knee, etc., etc. But really, it's because of the match made in heaven, the POCUS is. This is this child's mum, also my friend, and my friend's little one, Samuel, and he's fell asleep during his scan. He's been held up during it. So it's the match made in heaven of covering a kid in slime and showing them cool stuff on a screen and scanning them and examining using ultrasound, all right? But if I haven't convinced you, unfortunately, there might be headlines like this, okay? Or like this. And if only there was a way for us to spot appendicitis and pneumonia easily. But there's another thing that we see commonly, and again, I've seen this from this morning, from doing the X-ray checks over the weekend and the bank holiday. I had this same thing. A legogram in a 1-year-old kid, all right, so we get this, and then that's fine, so we get this, we get this, we get this. None of it's helpful, all right, and what happens is one of my colleagues comes along, or I come along, and we put a probe on, and we find our answer straight away from a hip effusion. We didn't need any of this, mainly because they say this child was 2, so doesn't need any of this for SUFI or for even an early Perthes would be, no guidelines talks about 2, although I wouldn't mind you doing a quick AP pelvis, but yeah, you're not going to pick up most Perthes like that. So yeah, scan the hip. And then if you look at a nice guidance summary of all of the causes of a limping child, if you guys are the senior decision maker in the department and it's 1:45 and you've got to mop up with the kids, I don't know if any of you work in, say, a mixed department where you've got to finish off with the pediatric queue and then you get back to adults, you know, all of these potentials could be the cause for your limp in a child, according to NICE. We had a kid, it wasn't me, it was my colleague, who was was on the floor, and the lad was about to go to theatre. He was a big lad with autism, 15-year-old, big heavy lad, and he was being consented for theatre for scrotal exploration with an intermediate twist score, and he was honestly being consented. and it was a bit unclear as to what was going on. He didn't look massively convincing, but they didn't want to take a chance. He was in a lot of pain. He couldn't walk properly. And my colleague came along and he scanned his hip and he found a hip effusion, and he re-examined the scrotum and he said, no, come on, it's fine. He's probably a twist of 1 or 2 and we've got our answer. I think we don't need to take him. And he didn't go to theatre and all was well. Other times, our orthopedic colleague got some very supportive consultants here. Actually, the main paediatric consultant is very into POCUS and really believes it. He's asked us to do some teaching with the registrars. He called me up to the ward one day and he said, look, this kid's, we're going to book for theatre, but I'm not as convinced about septic hip. I'm not too sure what's going on. Will you just come and have a look? We had a look. I said, absolutely no effusion, 100%. And he got an MR instead of going to theatre that afternoon, and it was a pyomyositis of the psoas muscle. You know, it was something totally different. It wasn't a septic joint, didn't need to go to theatre unnecessarily. But what about if you guys back in ED want to, use it quick and easy to streamline care? Well, a good friend of mine, Peter Snelling, did a trial called the Buckle trial, where he looked at buckle fractures of the wrist, where that's what they look like on X-ray, obviously, where he just runs a scanner quickly over them and gets them in and out. And this is a guideline we wrote. We've got about 15 of these guidelines in our department that I've written, and it's dead quick, it's dead easy, and you get a lovely answer. Now, did any of you get involved with the FORCE trial? I don't know, it's quite pediatric-y, but it was, we were randomized. It was about 3-4 years ago, randomizing to a bandage or nothing even, and a Futura splint slash fixate, definitive casting, and no follow up. And basically we knew the outcomes were going to be similar. So in other words, we don't need to follow these kids up, and we don't need to put anything on them really. You can give them a quick Futura splint if you want, which is what we actually still probably do, but they're low consequence injuries. The wrist will heal fine. So if all of that's true, then I'd argue, why do we need an X-ray? So we could just quickly scan them and get them out. There was a paper done by Dan Perry, which is a pediatric orthopedic guy, and some of the people from Peruki who looked at this, and they talked about declassifying the description of a buckle fracture to a bone bump, just a bump, a sprain or a bone bump. So we could quickly just do this and get them home, no follow-up, no nothing. And that's Peter's paper, which went in the New England Journal of Medicine, which was great. And even German orthopedic surgeons are doing this. So guys, we can't be left behind then from them. They're able to do it, and it's showing that excellent diagnostic accuracy and quick and easy, and improves outcomes. So I was worried I was going to run over time. I could find some more cases if needs be, but just to sort of try and bring it to a bit of an end, and then some questions. Back to our case at the start. So what do we and answer honestly, what might you do if we weren't having a talk about ultrasound? Any thoughts? Anyone want to be brave? So hands up there, who worries about safeguarding? Who's very worried? Yeah, as a senior decision maker, it's on you, remember. No one else is around. You've got to send them home. Okay. Who's medium worried? No one's answering. Everyone's too tired. And who's not worried at all about safeguarding? Anyone not worried about safeguarding at all? Because what if I threw you a massive curveball now and I said this is a cardiac case? That would be so funny, wouldn't it? Actually, this is a duct-dependent lesion. Yeah, that's funny. No, so okay, so we're saying we're at least medium to quite worried about safeguarding. Yeah, cool. So you could, I agree. It's it's a no mechanism, and do kids just wake up with problems? I don't know. What could they wake up with? It's almost certainly a fractured humerus, isn't it? The stepdad's being added again, that kind of thing. Well, the correct answer, you do something else. All right, and this is what I did. You put the probe on dead quick. And Gokul told me I had to speak about pulled elbow, which I thought, it's like, really, am I talking about pulled elbow and POCUS? But I honestly am, because it's been a game changer for us. And I've ended up with too many publications on POCUS for pulled elbow. I really did not want to be the pulled elbow person. That is the lowest hanging fruit condition in the world. But it's became a massive thing for us. I promise I won't get involved with these without using ultrasound now for lots of reasons. So we all know what pulled elbow is. And it's dead easy. All right, this is our image that shows the relevant anatomy. All right, so we've got the high frequency probe here. We're along the radiocapitellar line. Okay, that way so proximal to distal. All right, and what's happening is we've got the origin of the supinator muscle to the radial head. All right, we can't see the annular ligament here really particularly, but it's somewhere about here. And in the normal appearances, we just see a normal attachment of the supinator. We don't see anything here within the synovial region, and we don't get this sign, which is what you're going to see on the next slide, which is this thing called a hook sign, whereby almost if you think if this bit has been pulled a little bit distally, all right, it's almost like you're losing like a tent having its pole removed, where the kind of tenting isn't there anymore, so everything flops down in the synovium. The supinator muscle becomes entrapped within that region anyway, and we need to do a special maneuver, don't we, to reduce it back. So yeah, here's an example. These are just stills of normal, no hook sign, versus obvious hook sign. And I always tell trainees to just follow the fibers of the muscle. All right. So if you think this is muscle brachioradialis and this is muscle supinator there, these fibers, you can clearly see where the fibers taper up to a point, to a peak, and stop, or whether they go into the joint space called a hook sign. All right. And it's there. And we did this thing, it's the first time it had been shown, which is we've got the real-time reduction of a pulled elbow under POCUS guidance, so it's shown it happen in real time. So that's on it's on YouTube, or you can look it up somewhere. So yeah, it's a bit of a game changer, and that's because in our department we see regularly manipulations of pulled elbow that aren't pulled elbow. We did a study. I don't think I've got it here. I've cut this down just for time. But we did 107 elbow injuries. It was a retrospective look, and it was 37 of them got POCUS as a convenient sample based on who was in the department at the time. And we were able to show there was 100% sensitivity and specificity for the hook sign, which is expected, really. It's not unexpected based on, an endpoint of simple reduction being a diagnosis of pulled elbow and no other problems thereafter with resumption of function. And in that study, there were 2 fractures that were missed, and that's just in that small sample of 107. 2 fractures had been manipulated, not when we were there, as part of it. And we also, I think, showed something like a 36% reduction in unnecessary X-rays when we used POCUS. So there you go. You've been told about that game-changing condition, pulled elbow, but it's dead easy to do. We do, for training, I know you guys have courses up and down. We do ours. If anyone's interested, we're going to have our next date in February, which is where we've got a PEM specific course. I think I might have a QR somewhere, or if I don't, I think I do for the PEM POCUS UK. But yes, this is a PED specific course where we get kiddies in. We'll do skin and soft tissue infection. We can talk about appendicitis if people want to. It's going to cover all the normal modalities, but it's got other stuff as well. So have a look at the website and get in touch if there's anything you want to know about it. It's going to be in February. And then we set up this thing called PEM POCUS UK. I don't know if any of you guys have heard of it at all, but it's this thing we do once a month online. It's the talk, much like what I've done today. It's not always me speaking, don't worry, but we've got lots of other people up and down the country and around the world who've helped out. We've got one of my colleagues from the US is doing September, and that's a QR code if you'd like to be added to the mailing list, and you'll get a flyer like this just once a month, and you can join, and it's just good fun. It can be supervision. If people would like to bring cases, I would be thrilled if any of you guys said, look, I've done my course, I'm doing some scanning, and I'd like to bring some cases in the future. It would be brilliant if someone said, I'd like to look at a little topic for literature review and present one month in the next year or so. That would be amazing as well. And it's just a bit of good networking collaboration. We've ended up with 3 or 4 or 5 research studies and put in publications just from linking up with this, really. There's also a group online that's brilliant. If you'd like me to email anyone else a link, which is with the guys from Connecticut and Massachusetts, and it's quite cool because I was there one of my first weeks. I pitched up and we were sharing cases. And one of the doctors asked a question, and he said, "I'm Dr. Chen, and I'm from Yale. Have you heard of Yale?" And I was like, "I've definitely heard of Yale. Like, I'm chatting to Yale here. This is cool." But yeah, you'll find the Americans have been doing it for a few more years than us. But even then, everyone contributes different things, and it's just nice networking. So that's called PPEC, and it's on a Thursday evening at 6 p.m. East Coast time. So if anyone wants the link for that, I'm sure they'll happily let you join in. And then this is the last slide you'll be really glad to know, and it's just it's the slide I always end with, really. which, you know, I kind of para-read as your patients will like you more if you use POCUS. So, you know, lots of good endpoints there. Any questions at all?
Oh, thank you so much, David. That was excellent. And looking forward to the October talk in PEM POCUS as well.
Spot on. Yeah, good. Hopefully you're going to help out with that. Yeah.
Thank you. So
cheers, guys. Take care. Thanks. Bye. Have a good afternoon.